Okay, perfect. So let's try this again. So I'm introducing Dr. Becca Ichord, who's with us today in the audience. And she is a professor of neurology and pediatrics, and also the director of the Pediatric Stroke Program at the Children's Hospital of Philadelphia. And we're very grateful to have her today with us for this speaker event. So before we start the presentation, I wanna do a little bit of an interactive activity to kind of get to know our audience tonight. So we're gonna use a program called Pear Deck, and basically I'll screen share how it works, but you guys are able to answer questions live. So I will screen share a code that you guys can join directly from your phones. So yeah, it'll explain it here in a few seconds. Yeah, so if you could please go to join pd.com, and then you can put in this code to allow you to join to the presentation and then answer some questions live that we will be able to see your responses, anonymous responses. So let's see. I'll give you guys a few seconds, a few minutes to connect, and then I'll start once we have a few students join.
Alejandro, do you want me to go there as well?
I think it's fine. This is mainly for the students. But yeah, in a few minutes, you can share your presentation and start. Thank you so much for joining us, Dr.
My pleasure.
All right, so we have about 20 students now. So I'll start the class, but you can still join by putting in this code on the right hand side. So let's start. The first question is, where are you right now? And like, I know this semester has been a little bit different because we're all doing school online. So I'm currently in Florida. I know a lot of my friends are back in Philly, but just if you're able to put a dot where you are located now, just like in the state or another country, and we'll be able to show where everyone is right now. So I'll do overlay. So cool. So we have a lot of people in the US, and then some people are abroad. But yeah, it's very interesting. All right, let's do the next question. So what grade are you in? And I guess I'll show responses. So we have a lot of freshmen, sophomores, juniors, and a few seniors joining us tonight. Let's do our next question. So what are you majoring in? Or if you're a freshman and you're still not completely sure, just like write down whatever you're planning on majoring in. And I'll give you guys a few seconds. Right, so neuroscience. Yeah, I kind of did that. Yeah, so we also have some other majors, biology, neuroscience, and it makes sense. I mean, this is the Neuroscience Society, so HSOC, I like that. Psychology. All right, we have a few more, but I guess the overall trend is either like bio or neuroscience or other like STEM pre-med majors. And let's see, are you interested in a medical career? So yes, and we got some maybes. Perfect. So now I'm gonna go ahead and stop sharing my screen, and we're gonna have Dr. Ichord give her presentation. And you guys feel free to ask questions on the chat if you have any questions while she's giving her presentation. But we are gonna wait until the end of her presentation to ask the questions. We'll have a specific Q&A session, so please wait until we get to the Q&A session. So yeah, Dr. Ichord, let me enable that everyone can, that you're able to share, so that you can share your screen now. All right, I think it should be good now.
Okay, stand by.
Services, there are many directions, as you'll see.
And we ask everyone to please be muted at this time, so that we're able to pay attention to the presentation.
Okay, can you see my slide?
Yeah, we can see it.
Okay. Well, first of all, thank all of you for joining. I'm sure you have other things you might be liking to do on a weekday evening, and I'm here to just give you a snapshot of not just what I do on a given day, because what I do on a given day has changed over the years. I want to just give you an idea of how I came to where I am today and what brought me to child neurology. I'm happy to take questions along the way. Alejandro, will you be monitoring the chat box and letting me know if there are questions, or do you want to do all the questions at the end?
I guess whatever you would prefer. If you want, we could do them like while your presentation is going on, or the Q&A. Whatever you would like, I can do.
Yeah, if someone has a burning question and they're thinking of it at the moment, I'm happy to pause and chat about it, because I'm not conveying information that you're going to be tested on at a later time. So this is really just to give you an idea of what, you know, life was like for one person who became a neurologist. And so if this stimulates you to ask a question, then feel free to ask. So finding my home in child neurology has been a long and winding road, and I want to give you an idea why it came to be that way. And I don't usually share such personal things, but you might be able to pick me out because I'm staring straight at the camera. But really, I think it began with family. And I think our families give us our sense of our place in the world and what we value and how we relate to others. And these, I think, are really important attributes that just help us decide what journey we want to take in our own lives, and how we, how we find our talents, and how we overcome obstacles. So I was born to a farmer's family in the Midwest, and this is a family picnic back in the 1950s. And you can see adults and kids and everybody kind of just sharing the time and enjoying the moment. And so that sense of family, I think, is something that has carried me through good times and bad throughout the years. So I want to tip my hat to my foundations there in the family. And ultimately, after many different twists and turns, and after finishing college, I did decide I wanted to go to medical school. And ultimately, medical school landed me in Washington, D.C., where I found myself doing pediatrics at the Children's Hospital in D.C. And I met some people that made me begin to think a little bit about what I wanted to do once I finished my pediatrics training. And this is an example of the idea that you think you know what you want to do 5 years from now, and then you start along that path, and as you follow that path, you become interested or meet people along the way who spark an interest in you that you weren't really aware that was there. And I might have traveled a very straight and narrow path from my beginnings in medical school to ultimately a private practice in general pediatrics, because that's what I thought I wanted to do. And then along the way, when I was a resident in pediatrics, I found myself rotating, as all of us did, in the neonatology unit. And I looked at these tiny babies and wondered how on earth would they be able to survive such terrible illnesses, and what would their future hold? And the answer to that question lay very much with how their brain responded and how their life allowed them to recover from brain injury. And so in that time, I ran into and became very inspired by a director of the ECMO, or the extracorporeal membrane oxygenation program there, which was a life-saving therapy for neonates who had severe lung disease. And she was very interested in how those diseases related to the brain. And so one thing led to another, and I became part of her group looking at follow-up from these very sick neonates. And again, through some of her connections and some of my connections, I ended up deciding that I was not meant to be a general pediatrician, that I had this hunger inside of me for knowledge about the brain. And I didn't want to just be an onlooker from the outside. I wanted to be on the inside. And what that meant was that I needed to really study neurology and the neurosciences. So with a lot of luck and with a lot of hard work, I switched paths and I ended up becoming a neurology resident at Johns Hopkins. And so after having completed already 4 years of medical school, 4 years of training in pediatrics, 2 years of fellowship in developmental disabilities, and then 2 years as a pediatrician on staff at Children's Hospital. So by now I'm getting up into my 30s. And I just realized that I had this deep desire and passion to really be able to function as a true neuroscience clinician. And so after all of that time spent and effort in a career that was really not quite the right career, I then departed from that general pediatrics career and became a resident again. So I was accepted into the neurology training program at Johns Hopkins in Baltimore, where I could still build the bridge or continue to walk the bridge that had previously been built with some scientists that were exploring brain injury in the developing brain. And that's what led me to meet Dick Traceman. And he influenced my career for the rest of my life going forward. He was a passionate and very talented scientist who understood brain physiology and brain injury and was very interested in the developing brain. He had a very large lab with a lot of basic scientists as well as clinicians. And he welcomed me into that lab. And that's a model that's kind of hard to find these days. And it's becoming more and more specialized and more competitive to try and combine being both a clinician, as I was then a neurology resident, and a basic scientist. There are a few people who do that, and they, I think, experience both the joy and the terror of both of those paths. So I, worked in the lab there, looking at animal models of brain injury and studying physiology and writing grants and writing papers as a basic scientist while still completing my neurology training. And I stayed on at Hopkins in the neurology program as a faculty in neurology. And so that gave me, you could think of it as baggage, but really what it gave me was a legacy. So I started out, my legacy was in general pediatrics and neonatal brain injury, and I kept my relationships going with those people. And then I acquired a new legacy, or built on that legacy, by working in brain physiology and stroke and neuroprotection. And then fast forward another 10 years, and now I'm in the assistant professor on the end of my assistant professor level, and thinking about where I might go next. And I had been able to maintain relationships with a number of people in anesthesia and critical care and neurology. So one of the reasons I'm telling you this long and winding story is that it's, in a way, it's about building a family within your career spaces. And over these many years, I met people whom I valued, who served as mentors and peers. And those relationships persisted and lived on. And I was able to learn from those relationships and model those relationships. And they filled in many interesting places in my life and gave me many models to follow. And so as you go through your career, I would urge you to really value relationships and to think of those people with whom you form relationships as family members. And sometimes family members lose touch with each other and then see each other again over the years. So think of a person that you meet as someone who knows, you might meet them again in some other time, in some other place in your life. So remember the people, and keep a place in your heart and in your mind for those people, because you may never know what place they might, where you might find them again. So ultimately in 2002, I came up to Philadelphia and joined the neurology faculty, where my mission at that point was to help expand our knowledge and our programs and our clinical care for children who are critically ill. So from there, I again had the great good fortune of landing in a really top-notch institution that has many talented people, a lot of resources, and a way of forging new bonds with people who could help me carry on a mission. And that's where I was able to establish the stroke program. And because I was in on the basement floor, there really wasn't a field of pediatric stroke 20 years ago. It was something that was an idea in the minds of some talented and interesting people. And I was at a place where I could be one of those people and start talking about and developing the program. So if we then sort of picture where I am now, and where I am now here at CHOP is been my home now for 20 years. So let's talk a little bit more about what that looks like now that I've been in this home with my current family. So as I mentioned, I started out with the lab research, and one of the really interesting, and I like to think formative papers that we did was looking at the benefit of cooling the brain after a hypoxic ischemic injury. And this was an idea that was gaining traction back in 25, 30 years ago, and I was in a lab that could test that. So I had some really talented people around us, and we were able to show that if you expose an immature animal, in this case a piglet, and piglets are really interesting animals because they're very smart and they have a lot of features that resemble human beings. So this was pretty close to the human model, and we were able to survive these animals after an asphyxic cardiac arrest and show both with behavioral outcomes and pathologic outcomes that indeed hypothermia for 24 hours after this insult really did improve outcomes. And so I followed that thread and worked in general ischemic brain injury, but ultimately switched to a more specific kind of brain injury, and that is stroke. And ultimately, after lots of hard work and lots of partnerships with people who are interested in stroke, I had, again, the good fortune of being able to put together a study that developed a new tool that we could use, adapted from adults, to measure the severity of a stroke. And this was just a building block that was necessary in order to move forward with the research in stroke. So we were able to get about 15 pediatric stroke centers around the country and in Canada to do some testing in children who were in the hospital with acute stroke to determine that this manner of measuring stroke severity was valid and useful. So you might ask, why pediatric stroke? What was the draw for this? And it grew out of this idea that had developed in the 1990s in adult stroke, that time is brain, and that we have an opportunity and, in a way, a challenge to take an action in the early course of an injury with stroke that might forever affect, in a hopefully beneficial way, that person's outcome. So I was in the middle of working with a whole network of pediatric stroke experts, and we wanted to bring this way of thinking and this way of treating children with stroke, and to get the benefits of this kind of approach that's well accepted in adults, to bring it to children, because it did not exist back in the 1990s and early 2000s. And so we wanted to bring that to the care of children. So I was really motivated and felt there was a lot of potential for doing that. And so there are certainly lots of guidelines for how adults can be treated. And back in the 1990s, people began to think about stroke as a brain attack with as much urgency as we think about a heart attack. And so stroke centers began to develop, and teams and care pathways began to develop for adults, and I and my colleagues around the country wanted to do the same thing for children. We had to overcome a lot of preconceived notions, and one of them was a widespread notion, even among doctors, that children don't have a stroke, so why should we do this? Well, I was convinced otherwise, and I felt that there was a lot to be done to improve awareness and to bring research on stroke to help these children get better. So I realized along the way that stroke actually comes in several different flavors, you could say. There is arterial ischemic stroke, which happens when there is a blockage of an artery and deprivation of blood supply. And then there's clot on the venous side, which is somewhat different entity, but also is very time sensitive. And then there's intracranial hemorrhage. And so our team and our pathways provided care for all of these children. And in each of these cases, caring for these children and developing programs for these children expanded my knowledge. Did I come into this having completed a fellowship in stroke? Absolutely not. I had to teach myself and learn from taking care of patients, and I learned from colleagues and mentors. And that was both fun and difficult. I would say it was more fun. Fun in the sense it was intellectually fun, because ultimately my biggest passion was really understanding the brain and understanding how the brain of a young person responds differently than the brain of an older person. And this to me is the true final frontier of the neurosciences. The neurosciences is really many different versions of the brain and of the nervous system according to age. And so you can spend a lifetime studying a particular system or a particular disease just in one age. If you then expand that out and study those systems and those structures across the age span, well, your curiosity will never be satisfied. And you'll always have new questions and new interesting ideas and new observations. So that joined my passion for neurosciences with that of pediatrics. And there's just no better, more interesting subject than the developing brain. Not that I'm trying to sell you on it, but I guess I am. The developing brain is just the most fascinating thing in the world. So getting back to the pediatric stroke program and problem, people often ask me, well, how big a problem is this? And so we accumulated a few statistics, and it happens to be, oh, this number doesn't mean very much just taken by itself, but what it takes on a little more meaning if you understand that it's actually comparable to the incidence of brain tumors. It's understandable when you understand that it's among the top 10 causes of death in children. And more importantly, it leaves more than half of survivors with long-term disability. Moreover, there's recurrence in 20 to 30% of patients. So we have opportunities and challenges in taking care of each child at the time of their stroke, but also preventing recurrence. So when we first started out, we asked ourselves, well, what is the optimum treatment? Well, nowadays in medicine, we're all very driven by finding evidence that supports the treatments or the turning away from inadequate treatments. And when we first started out on this journey, there was almost no evidence. So right away, it became very clear that there was a tremendous need and great gaps in the research to help us decide what treatments we could do and which ones were effective and which ones weren't. We also didn't really understand how we might predict the outcome of a patient at the beginning of their journey. And we needed these valid clinical assessment tools. The opportunities at CHOP were tremendous because it was a big hospital with a high profile and a great deal of talent and resources. We could set an example, and we could develop a program that could be what I said when I sold this to the board of the directors was, we're going to do it first and we're going to do it best. That was pretty bold and probably a little bit high-handed, but you know what, if you don't aim high, you're never going to reach high. So we became really the first US pediatric stroke center that was supported by the hospital and that had very formalized pathways. And as a result of that, and just again, because of the talent that I was surrounded with and many resources that I had, we were able to be part of a group of international leaders. So it was really exciting, and continues to be exciting and a great source of reward. And we wanted to lead in clinical care and research and education, because this is the triad that really drives academic medicine. And I wanted to be able to say that we contributed in all three of those areas. So how did we do this? So we had this kind of interrelated goals. Patient care, we wanted to develop a rapid response team. We wanted it to be multidisciplinary, and we wanted it to work for children over the lifespan of their insult and their recovery. We wanted to have research, both clinical and, if possible, in the lab. We wanted to be able to train not only our own stroke neurologists, but we wanted to contribute to the training of other doctors and support staff that are needed in caring for these children. And this is one of the, just kind of emphasize that this multidisciplinary and transdisciplinary component of this area of work was one of the great draws for me. I get a little bit bored a little too quickly if I'm in a very small world, and being in the stroke field allowed me to work very closely with doctors and other experts who were not in my field. And so I learned a lot from emergency physicians, from intensive care doctors, from neuroradiologists, from nursing staff, rehab experts. So you name it, there's probably a dozen or so different disciplines and subspecialists that are involved in the care of these children. And I loved that. I loved being able to learn from them and work with them to help a family and their child cope with their illness and recover. And then there's a community outreach. There's a larger community outside of the medical center that we need to communicate with and we need to relate to. So our children leave the hospital after a short stay or sometimes a long stay, and they have to go out and live in the community. So what happens when they go out in the community? Well, they have teachers in their schools who have a role in helping them to recover and in helping to detect when they have a new problem. Of course, they have their family, and their family is their first line of support and treatment. And then even beyond that, there's public policy and social structures. We're all acutely and painfully aware of the effect of large systems of public policy and politics and how this reaches back down and affects all of us. So depending on the lens that you put on, you could approach this problem of the child with stroke from many different ways and think about an opportunity and a challenge of, how can I influence a given child? How can I influence the field? And it's just, a very interesting kind of entire universe of care and of experts that play into this. So I love thinking about this, and I can interact with many different people in many different scenarios to address this. And this is just another way of looking at this journey. So at any given time, you might have many different people who play a role, but then over the course of time, a child has to travel this kind of journey, where in the beginning, someone has to notice that something is wrong with them and they need to be able to be taken care of promptly and get appropriate early diagnosis. And then they find themselves in the inpatient acute care setting. And so I can interact with that patient and have an influence at their journey in the emergency room, in the inpatient intensive care unit, in the inpatient rehabilitation unit. And I've been able to set up an outpatient multidisciplinary stroke clinic. And then beyond that, the patient is out in the community, but they're coming back to see me and my team at many stages of their life and their recovery throughout childhood. And now that I'm getting old and gray, I have lots of patients that I met, even a few when they were newborns, and now they're entering college. So this is one of the really beautiful things about being in a field like neurology, where I have a chance to touch that child's life over many stages of their life, and seeing them and their family grow and recover and advance into other stages of their life is incredibly interesting and so very rewarding. So that's one of the things I love about it. So I'm just going to skip that one. So I'm just going to give an example of a patient who we met early on in the course of developing our program, so you get a flavor of what this might actually look like in a practical way. So here was this young woman, a 13-year-old, who was attending the clinic because she has a condition called neurofibromatosis. And this condition caused her to have some low-grade brain tumors where she was getting regular follow-up and treatment for that. And out of the blue, as she was in their clinic visit there, she suddenly became paralyzed on the right side and completely unable to speak. This developed over about 15 minutes. And the clinic staff that was caring for her in the oncology clinic recognized right away that these were symptoms and signs of a potential stroke. So they did what we all programmed ourselves to do, and they called the stroke alert, which activated a group of people to meet her and to set up a plan of assessment in a very rapid manner. And so she was able to get a brain X-ray and to start some treatment. And the treatment was actually very simple. All that we needed to do was to have her lie flat and give her some IV fluids. And what this did was to kind of augment the blood flow past an area of blockage in one of her arteries, and she improved quite quickly. So this is the pictures of her arteries in her brain. This is a type of imaging called magnetic resonance imaging. And what it pictures is flowing blood in an artery. And this is her right side and this is her left. And doesn't take much to realize that there's something completely terribly wrong with her left artery, her left carotid artery, and this was what was responsible for her having her symptoms, because there was a loss or a temporary drop in the blood flow to the left side of her brain. This is another type of image that we're able to do with the MR scanner called perfusion. And this is an example of how technology for imaging has changed so dramatically in a very rapid time. And what this does is, when you're in the magnet in the machine doing this other imaging, they apply a magnetic pulse, just a short pulse that gives some magnetic energy to the blood vessels in the neck. That short pulse of magnetic energy can then be detected as it flows into the blood and the tissue in the brain, and it causes the blood in the arteries and in the capillaries to appear a certain way. And what you can see on one side is one side's very dark, and that tells us that the label is not getting to that tissue in a normal way. Now, if this were a different scenario, say a patient with a heart attack, with heart disease, in that scenario, the blockage might be due to a clot. And a clot nowadays can be treated very rapidly with either a clot lytic agent or with a device that removes a clot. So in a different scenario, this process of rapid recognition, rapid assessment, rapid imaging could lead to an acute definitive treatment. In this patient, she improved just by giving her improved circulation with IV fluids. And ultimately, then she did better. And this is an example of a type of image that we call diffusion weighted. In the case of a diffusion weighted MRI, an area where there's acute ischemic damage will look bright. And so we were absolutely thrilled when we saw this part of her study and could see that she, in fact, did not have a big stroke, that the intervention of just simply giving her IV fluids and lying her flat, which is just ABCs of acute stroke care, averted her having a stroke. So we were quite pleased. And this was an example of how we felt quite a bit of success, that our stroke pathway was doing what it was meant to do. And this was very rewarding. And it only took a few years after we established our stroke pathway for this to become kind of embedded in culture at CHOP. And so I've always been very gratified that this was adopted and became part of the way of thinking and part of the way of treating patients at CHOP. Yay, us, we did it. So what about research? We've linked many different types of research programs to the stroke clinical pathway, and this is kind of the ideal of academic medicine. And here in the center, you see we have a registry where just about every patient who we met, we would enroll them in a descriptive registry, which allowed us to just simply collect clinical data. And then we had imaging experts and biostats and data management that helped us to put to use the data that we collected. In addition, there were various other studies that were connected or going on in parallel, studies looking at sickle cell anemia because this is an important stroke risk factor. There were people who were studying the effect of stroke on cognition and development of neurocognitive skills in children. There's a big lab led by Dr. Licht looking at cerebral blood flow and ischemia and circulation in congenital heart disease. We had our stroke scale, and there have been various other studies that have come along the way. And what I put up at the top here is something called the International Pediatric Stroke Study. And this was this network of international child neurologists and a few other allied professionals who joined back in about 2003. And we all pledged that we would submit our data on our patients that we met clinically into a big registry. And over time, this network grew. We met every year. We analyzed our observational data, and then a number of those investigators submitted grant applications to do more specific funded grants. So this organization has grown, and this is yet one other example of another family that I've been able to be a part of. And so we've had these very productive and very enjoyable long-term relationships with colleagues who come from all over the world. I met some pediatric neurologists in Argentina, in London, in Italy, and have had the great pleasure of keeping in touch with them and being able to visit them while at the same time working together with them. So again, this idea of family keeps coming back, and it's a wonderful way to enjoy the work while at the same time getting some really nice productive results and feeling like you've accomplished something. One of those, or some of those relationships turn into vacations. So when you get to be my age or about my age, you get invited to give lectures and guest lectures, and as a result, you get to meet more people in distant places and really enjoy those countries and those cultures. So we kind of built our program. We put ourselves online, as everyone does, and this is just an example of one of our early website pages, which is a place where other providers and other people in the public can come and see what we're doing and what we're about. And I just want to say that the international organization itself has grown and developed. So the work that we do is almost like raising a child. And our early network had maybe 20 people in it. And over time, there probably are now 100 people. And in addition to a research organization, we now have a much bigger organization that aims to do not only research, but to be leaders in clinical development, education, and advocacy. And we're calling this International Pediatric Stroke Organization. We think of it a little bit as a cousin or a parallel to the American Heart Association and other international organizations that really, whose mission is to improve the care of people who have stroke. And so now we have this for pediatric stroke. So where do we go and what do we continue to do? We continue to aim to translate research to practice Here's an example of one of my fun little patients who had a stroke in the neonatal period, and now here he is, I think it's a she actually, walking and playing and talking, and so it's really interesting to see how each child, even though their MRI might look different, might look the same, it's a very different path that each child follows. And so we have much still to learn about why one child's brain heals in a different way from another child. We also understand and learn that there's a lot that the parents and the families have to do to help those children recover. And that we're treating not only the child, but we're treating the family. And this is one of the common themes of all pediatric subspecialties. We take care of the whole family. And in many ways that's challenging, but on the other hand, I think there's a great deal of gratification that comes from treating the family. If any of you have been ill as a child or have a family member who is sick as a child, or if you even have your own children, you probably know that there is no greater gratification that you can feel as a provider than to look a parent in the eye and to see their gratitude and see their hope in their eyes for the help that you can give their child. There's just no better feeling in the whole world. Of course, the flip side of that, there's no greater tragedy. But by far and away, the gratification and the gratitude that those families feel toward us far, far outweighs the negative side of it. So this is one of the really, really most important reasons that I get up in the morning and go every day and see my patients and see their families. It's because I become part of their family and they view me as someone important to them. And it's a wonderful feeling. Now, more recently, there have been lots of really exciting advances in rehabilitation. And with the advances of technology, you might have heard about things like transcranial brain stimulation. So we can use magnets, we can use low voltage electrical devices to transmit signals and energy to the brain. And this can alter the signaling and the network function of the brain. And this can be put to use in combination with other rehab therapies. So there are programs that we think of, or we call intensive movement therapy. These can be partnered with brain stimulation, and they're even now, one of the most cool things I ever saw was at a rehab conference last year, where some children were being taught to use a computer interface, and just with thinking about how to operate a computer-assisted toy, they were able to do it. So to me, this is like science fiction, but it is not science fiction. It's here and it's real. And along with that is the whole idea that what we can do in person, what we used to always do only in person, we now are doing by telemedicine. You know, just the fact that I'm here with all of you by Zoom is a lesson that we can take our medicine, we can take our relationships, we can take our assessments and treatments into the virtual world. And this opens up lots of new opportunities. So as you guys come into the field, you're much more tech savvy than I am. You're going to be much more able to cross these disciplines between technology and basic sciences and the clinical realm, and bring those innovations and bring, you know, thinking outside of the box is going to be much easier for you than it has been for me. So this is incredibly exciting, and I'm sure you're learning about more examples of that as you do your neuroscience, but you might be very surprised to know just how far this has come already, and I'm sure it will grow and become even more exciting in the future for you when you arrive at your next place in your journeys.
Dr. Ichord, we
Yeah.
actually have some a lot of questions in the chat. So is it okay if we jump
Yeah.
into this now?
Sure.
Just before that, I want to make an announcement. I know a lot of students are here. We have a virtual physician shadowing program, so they are required to attend speaker events. So at this point, I will send the attendance form, and make sure if you want to be considered, just fill it out before 7. So that we can count that towards your presentation. And now I will hand it over to Heba, who will lead the Q&A session. So she will do
That's fine. I think I'm at the end of my presentation anyway, so go for it.
Okay, perfect. And thank you so much for your presentation. It was very inspiring to hear your story and your passion. Thank you.
Hi, Dr. Ichord. Thank you so much for that presentation. It was very interesting, and I know I learned a lot from it. So
I'm glad you did.
Of course. So we have quite a few questions in the chat, so I can ask them, and then I'll just move on to the next one as you answer.
Sure, fire away.
The first one we have is, are there any resources you would recommend for pre-medical students interested in neurology?
Oh gosh, I think probably the most useful thing you could do is find someone and meet them and get to know them and attend them to their clinics, sit down and talk with them, have coffee, talk about your dreams, and find out how your dreams could be translated into your reality. And I think that happens best at a one-on-one basis. There are meetings that where it's possible to meet a variety of people. So the professional societies like the Child Neurology Society, the American Academy of Neurology, many of them have activities that are designed to reach out to students and potential future trainees. So you can go to some of those websites for Child Neurology, American Academy of Neurology, and see what is on offer for students to get involved. In fact, even here in Philadelphia, there are programs for students as young as at the high school level. So go ahead and reach into those organizations to see what's there for you. And then as you have the chance to meet individual professionals, I think that gives you a window that just there's no substitute for going there and being there and seeing what it's like to be on rounds, to sit in the clinic, to sit and have coffee with someone. There's lots of volunteer opportunities. I think many labs and research groups find ways to bring student volunteers into their research programs, and that's a good way to get a flavor for what it's like for what we do as researchers.
Yeah, that's great. Thank you so much. The next question we have is, throughout your educational career and even now as a physician, have you been able to maintain a work-life balance, or do you find it to be challenging with research and clinical care?
Oh, that's a great question. And the fact that you're even asking it, I think, is a step in the right direction. It is always hard. And in my own journey myself, there have been times during my career where I did not have a good work-life balance, and where I sacrificed or probably didn't pay enough attention to my own well-being and my own balance. And I think if you're aware that that is something you should pay attention to, then you're going to be better off. What I would say is that each of you has things that bring joy to you, and activities and hobbies and parts of yourself and your inner life that are not specifically driven or related to your work. Art, music, cooking, literature, all of these things are what make us complete human beings. And so if you have a talent or you have a love of something like that, keep it alive and keep it going. And understand that if there are times in your life where you don't quite have time to do those things, try to understand that the windows will open at some point, the air will come in, and you'll be able to do those things, but don't let go of them. Value them and keep them in your life in some way or another. In my particular example, I grew up, again, coming back to my family and my origins, I was surrounded by music all the time. There were many singers and musicians in my family, and I participated in a lot of musical activities growing up, and I had let go of that during my early training years, and I think that was a mistake and a loss for me. And then as time went on, I rediscovered it, and I found that singing or even taking on a new activity like dancing, for example, I became a tango dancer. And this has brought me tremendous joy and has given me a way to offset the continually changing stresses and burnout that all of us feel. So keep alive those part of yourself that give you joy and that distract you and allow you to escape from the demands of work. Because your brain and your emotional well-being needs to have that balance. So there's no one formula that works for everyone, but what I think does work is paying attention to it and investing in it throughout your career. Dance, sing.
Thank you.
Draw.
The next question we have in the chat is, how do you balance research and clinical patient care?
Well, that's another very good question, and each person does it in a slightly different formula, and it also balances a different way at different times in your life. So when you're very young and junior, hopefully you're in a place and you've structured your work in such a way that you are investing more in learning how to become a researcher. So for example, when I was early in my faculty career, I had a career development grant that allowed me to be working 75% of my time in the lab. That's kind of the luxury way of doing it. And not everybody wants to do that. And so there are many different ways that one can balance research and clinical work together. An example is at CHOP, we have what we call different tracks for faculty. And you can have a straight up just academic clinician where your main academic and scholarly productivity is teaching. And then we have what we call the clinician educator, where you're about 60% clinical and no more than 40% or 30% research. And then we have the full-on really basic scientist who is 75% research and 25% clinical. So each person arrives at that some one of those varied formulas according to what they are good at and what they like to do. And very few people know at the beginning of their career, and by beginning I mean as a, say, undergraduate college student, what is going to make you happy and what mix and what balance is going to make you happy. And so the only way to do that is to go out and try it on and spend a month or two in someone's lab or spend a month or two in someone's clinical research activity. And you may start out doing it one way, and then over time you realize that you're more productive and you're happier if you change the balance a bit. So the answer is it varies and it depends. And one of the things you do throughout your career is to continually take your temperature and assess, is this really what I want to be doing? And don't be afraid of change. It's very reasonable, very appropriate to change if what you're doing isn't working and isn't making you happy.
It's a great response. The next question we have is, what are the risk factors for childhood stroke? Is it largely genetic, or are there prenatal factors that may contribute as well?
Oh, that's a great question. Depends a bit on the age of the child, because the risk factors are going to change over the lifespan. What I can tell you is they're not the same as in adults. The neonate, for example, the risks just have to do with being a neonate and with the maternal, fetal, placental environment. Once you're outside of the neonatal period, then the risk factors are generally divided into cardiac, abnormalities of blood vessels, and abnormalities of the clotting system. This is for ischemic stroke. And so some of those abnormalities are genetically determined. Many of them have very weak and very multifactorial genetic determinants, but specific genetic diseases are rarely or only in a very small number the determinant. Many of them have to do with exposures that children have. So for example, children are exposed to lots of viral infections throughout their life, and it happens that certain viruses find their way to the arteries in the brain, and they cause trouble in an artery and cause it to become inflamed. And the prime example of that is chickenpox. Varicella attacks arteries in the brain because it invades nerves. And nerves, you can think of, you have a set of nerves that innervate your face, the trigeminal nerve, and those nerves also innervate the arteries. And chickenpox is one of those what we call neurotrophic viruses. It gets into the nerve axons, and then it winds its way back up and lands on an artery and invades that artery. So it's just, you know, one example of how you have an intersection of an exposure like a virus, a host factor, the child being kind of vulnerable to viral infection, and anatomy. And there you go, you have a stroke. So it's many different causes, many different risk factors, and they're all different than they are in adults.
Perfect. And we have one last question just because time's running out. So someone asked, is neurology often a mixture of research and patient care?
Well, it's what you make it. In an academic center like CHOP, everyone's engaged in some kind of scholarly activity. But academic neurologists only make up maybe, I don't know, 10, 20% of all practicing child neurologists. So I would say research and practice together is only a part of a small minority of all practicing child neurologists. And that's probably as it should be, because there's much more need in the general population for pure clinical care providers. But for me and for those of us in academics, the reason we're in academics is because we love to teach and we love to ask questions, and we combine that with taking care of patients.
Perfect. Thank you so much for all of those answers. I know I had a really good time listening to your presentation.
I'm glad you all enjoyed it.
Thank you. And for everyone else, we do have a few quick announcements for the club that Jillian will announce now.
Yeah, so thank you so much again. I got so much from that. For everyone in the club, I just want to make sure that you're aware of some upcoming events we have this month. On October 27th, we have our second speaker event with Dr. Levine, and he will be talking about a career in clinical neuroscience. So the Zoom link should be posted for that in the last email that was sent out. Otherwise, we should update the Facebook with it as well. We also have a game night that we're still trying to pick a date on, but it should be happening at the end of the month. And just make sure you keep your eyes peeled for any upcoming emails that we might send out at the end of the week. For instance, I know that we're going to be giving some information out about a book club that the Center for Neuroscience and Society is hosting this month. So again, just keep your eyes peeled, and yeah, I think that's all we have for now.
All right, thank you so much, Dr. Ichord, for your presentation, and thank you to everyone who showed up. We hope that you stay engaged with the club, and yeah, it's nice seeing people here since we haven't had too much interaction this semester, but I hope everyone takes care, and yeah, stay healthy, stay safe. Thank you again, Dr. Ichord.
My pleasure, and thank you all. I know this is really tough time for all of you, that you can't be learning in the way you want to learn, you can't be with each other. And I think you're so brave and so committed, and just carry on and things will get better. I'm so glad you're there. We need your youth and we need your passion. So keep it going.
Thank you so much. Everyone stay strong, have a nice semester, and yeah, take care.
Bye-bye.
Bye.
Bye, thank you.